Assalamualaikum. I'll be presenting a case of a 49-year-old female. She presented with progressive weakness of all four limbs, but the right side of the body was more affected than the left side. She had those complaints for the last, since August then. Initially, it started in her ring and little finger. Then she developed the weakness of her right upper, followed by the weakness of lower limb that was associated with difficulty ambulating and holding objects and performing fine movements. And she required assistance for even ambulating, and she did complain of having current-like sensations in right upper and lower extremities, and a sense of heaviness in her upper and lower extremities. Her MRI cervical spine showed a C6 and 7 intradural extramedullary lesion. She underwent the excision for that in December 2025, and her histopathology showed it was a neurofibroma. I've shared the micro all the features with that. It was an unencapsulated lesion composed of monotonous population of spindle-shaped cells showing wavy nuclei in a background of a thin-walled blood vessels, and no anaplastic features were seen. I have shared her pre-op and post-op MRIs.
Okay. We can ask Dr. Shayan also for her opinion in between and for the radiology.
Yeah.
All right, so these are pre-op images from August 2025. And in the upper row, we have T1 image, sagittal image, in which the midline image shows a hypo intense area at the level of 6, 7. And if you look at the lower row, this is coronal T2 weighted sequence in which we can see there is a dumbbell-shaped lesion which is arising from C6, C7 level. Yes, this one. And next image. No, go back on the coronal. Yeah, so on this coronal image, in the second row and second image from the left, we see the entire extent of the tumor. It has a small dural extramedullary component, which is causing significant compression of the cord. A large extraforaminal component, which is extending into the paravertebral muscles. So it has a typical dumb appearance, heterogeneous T2 signals, low signal on T1, and homogeneous post-contrast enhancement. So based on these features, the first differential would be a schwannoma rather than a neurofibroma, because they tend to have a low signal on T2 as well because of their composition. Right. So this is the sagittal image. Here you can appreciate the intradural extent of the tumor, which is shown in the last row, lower corner. Yes, and this is the intradural component, and you can appreciate how significant mass effect it has on the cord at this level. Again, axial images, post-contrast sequence. In the middle row, it has already been outlined with a pen, and you can appreciate the extent of the tumor and can see significant displacement and compression of the cord towards the left side. Other than that, rest of the areas are normal. Yes, we can also appreciate disc ossified complex at C4, C5 level, which is causing mild thickness and indentation, but no significant canal or radicular compression. So at this level, rest of the levels appear normal.
Okay.
Over to you.
Okay. So Yamuna, she underwent the surgery. In which month? In December, right?
She underwent the surgery in December 2025. She stayed fine. Both neurologically, post-surgery, her neurological status improved. Her powers improved. She was able to ambulate freely with ease, and numbness reduced in upper limb. But she does complain it is still persistent, and she still faces difficulty holding some heavy objects. Her first post-op MRI was done in May 2026. Can we have Dr. Shayan comment on the post-op scans?
Yeah. So I can just give one more information. So she came to me and in August or September, and I told her she needs surgery, but she needs surgery with intraoperative neuromonitoring. And so I referred her to the center where they have the intraoperative neuromonitoring, since I do not have currently available at my center. So then she underwent the surgery, I think, in December, and but then a post-op again, she came back to us. There was a minor complication of some CSF leak. We managed that, but there was no post-op scan done after the surgery. So then we did the scan in May. We did a CT before to see if there was anything like with the infection or something. And then the May scan is here, Dr. Shayan.
G. So we have these T1 sagittal images, and in the lower row, you can see that there is evidence of a C6, C7 laminectomy and some soft tissue thickening in the posterior paravertebral soft tissues and subcutaneous tissue. And in the upper row, you can appreciate that in the first two images, we can see a lobulated lesion, which is extraforaminal. To better appreciate, we have other images. Can you move on? Right. So there's on axial images, we can see that in the top left corner, the lesion is still present. It is a very small component, but now the mass effect has significantly resolved. Now you can very well visualize the cord, which is mostly in the center, and the intradural component has significantly reduced in size. Possibly when we look at the post-contrast images, we'll see that it's more like a thin capsule. Um, but of course, the extraforaminal component is still there. Right. So on these images, you can see that the lesion is appearing hyperintense, and it has a very small intradural component. Possibly the capsule of the lesion is there, but the extraforaminal component is still persistent.
Right.
Yeah.
But this is all the residual, right? And even the neural foramen, right, Dr.
Yes.
Shayan, right?
Yes.
Okay.
The nerve is still involved.
Yeah. So her myelopathy signs and symptoms have improved significantly, but this thing is still there. So one thing that we wanted to ask to the board, like, so since we have the disease, residual disease, significant residual disease, so what we should do, should we just wait based on the histopathology, or we should plan something else? Dr. Asim, sir, we can have your opinion first, and then what do you think about this?
So is there any other, because if this patient is a candidate for NF2, because the histopathology is neurofibroma, and is there any other part of the body that also has this lump-like lesion over the body, or is this the only focal site?
This is the only focus site. We did explore about that. We did ask, and so yes, no signs and symptoms of NF2, sir.
Okay. So as far as pure neurofibroma is concerned, usually the treatment is actually the surgery.
Right.
Radiation, the role of radiation therapy is minimal, and you can utilize it but at the last resort if you don't have anything available to offer. So considering if her symptom is getting improved after surgery, regarding this extra axial or the paravertebral tissue, so if it is not causing any symptoms, one can just follow that thing. It doesn't need to be uh, need any intervention right now. But if the patient's symptom get worse, then definitely this patient this need to be removed as well if possible. Otherwise, we need to see the option that is very minimal. For example, radiation therapy. I don't think so. The radiation therapy has any upfront role in neurofibroma because one of the important thing is that because these are the benign conditions. So if you offer radiation therapy, then you put patient into the risk of mutation later on. That may lead to the second malignancy and all this kind of stuff. So it is better to just follow patient, or if the symptoms is getting worse, then need help from our surgical colleague. Thank you.
सही से सो हम फिर इसका ये कर लेते हैं कि एक 6 महीने के बाद या 1 साल के बाद एमआरआई रिपीट करवा लें राइट सिंस इट इज न्यूरोफाइब्रोमा एग्रेसिव डिजीज नहीं है व्हाट डू यू थिंक सर
So what is the compliance of the patient regarding
they
the
are pretty
follow-up?
good they're fine with that मतलब अगर हम उनको कहेंगे तो they will follow the advice
So if the patient compliance was good regarding the follow-up, then one can actually repeat. I would more inclined toward get a MRI earlier, this
okay
first time. If this disease is still stable, then one can actually increase the frequency of repeating the MRI. But because this is the first MRI after post-op surgery that was done in December, so it is almost 4 months down the road. So we
right
can actually repeat the next scan 4 months down the roads or earlier if clinically indicated. Thank you.
ठीक है sir perfect okay so we have today
One of the
Dr.
sorry,
जी
ऐसा
नहीं नहीं सर
one
आप
need to
बताएं
जी जी one important thing is because this patient also require a follow with the medical oncologist to just see the other sign and symptoms of NF
okay
because we have to actually exclude all those things apart from this.
ठीक
In the MRI, so do we have the MRI whole neuro axis and this is the only MRI the cervical spine?
सर इनका सिर्फ यही एमआरआई है
Mm.
न्यूरल होल न्यूरल एक्सिस का नहीं हुआ
So it is better. So when we get this the next round of MRI, it is better to get a whole neuro axis evaluation so that because it is an NF type of thing that there is a risk of having this kind of lesion other side as well.
Well, no, that makes sense. Perfect. Actually, Dr. Asim, we have Dr. Zainab also from our center, and we are also today fortunate to have Dr. Aisha Maiman with us. So we can also discuss एक दो points क्योंकि डॉक्टर शायान ने जैसे बताया कि वो उनके डिफरेंशियल्स में schwannoma would be on top, but then this came out to be neurofibroma. So what are the main those differences? Dr. Zainab, if you can just tell us a little bit about the differentiating fact चीजें between neurofibroma and schwannoma. Sorry, we do not have the slides. The pictures जो होती हैं उसकी मैं सिर्फ आपसे question for our understanding या जो हमारे पास इस वक्त participants हैं. We-
Yeah, sure. No issue with that. But before I answer your question, can I ask where was the histopathology done?
SKM.
SKM. Okay. And probably they received like a resection sort of thing because they commented on the capsule as well. Something like that. It
Maybe.
must have been a large biopsy. Yeah, so basically both are benign peripheral nerve sheath tumors. For neurofibroma, what we have is that we have a diffuse sheet of cells. It's not very cellular. The cells are quite far apart for easy concepts. The nuclei, they are wavy, and the collagen in between is what we call as the shredded carrot collagen. Very small wisps of delicate collagen are present between the cells. For schwannoma, what we have is that basically in the bulk of the tumor, we have hypo and hypercellular areas alternating with each other. And at the point where they meet, these hypo and hypercellular areas, we have cells which sort of radiate out of an acellular core. And these areas, we call them Verruque bodies. They are very pathognomic of schwannoma. I don't think that any histopathologist would actually mix neurofibroma and
Okay.
schwannoma up if they have ample
Okay.
material.
So
Yeah.
there should not be a doubt about this. So, ठीक है, this is perfect. एक और सवाल आप इसी से
I would
कि
just
हमारे
like to add one thing, Dr.
Yes, Dr.
Hassan,
Aisha. जी,
in
Dr.
addition
Aisha.
to Dr. जो Zainab ने
जी,
कहा है,
ma'am.
there's usually जो schwannomas है, they are well encapsulated, so you usually have a capsule all around them. And neurofibromas do not have that, and they have kind of an infiltrative pattern into the surrounding tissues.
ठीक बिल्कुल। थैंक यू डॉक्टर, थैंक यू डॉक्टर जैनब। आई वांटेड टू आस्क कि अगर हमारे पास ऐसे हिस्टोपैथ है जो कि एसकेएम से है, फॉर एग्जांपल जो एकेयू से होगी वो तो वी कैन रिक्वेस्ट देम, कैन वी आल्सो आस्क एसकेएम टू शेयर सम स्लाइड्स लाइक विद अस फॉर द ट्यूमर बोर्ड? क्या उन वो कर सक हम ले सकते हैं उनसे?
Bilkul, sir. I can try my best, and I think that we will be able to get them.
ठीक, परफेक्ट।
Yeah, अगर मुझे इन पेशेंट्स के MR नंबर like 2 to 3 days पहले मिल जाएं, so
ठीक है,
it becomes very easy for them to pull out their slides, and I can ask one of the fellows or the consultants there to ask one of the residents to send me the slides.
I think that would be great for all of us. Thank you, thank you.
Yeah.
Okay, let's
Okay.
move.
Thank you.
Dr. Tyson, do we have a written report for this histopathology?
We have written report. I think हम वो जो
You can
शुरू
put
में
out that
उन्होंने
on the
टेक्स्ट
slide as
लिखा
well.
था ना, वो शायद वहीं से कॉपी किया था, बट वो जो पूरा पेपर है आई डो नॉट नो। हमारे पास होगा डेफिनेटली यमुना, वी हैव।
Provide them.
सॉरी।
We do have both. We can provide them.
ओके, सो हम नेक्स्ट टाइम ये भी कर सकते हैं, अगर हमारे पास पिक्चर्स नहीं है, आई थिंक डॉक्टर शायान जो कहना चाह रही हूँ कि हम उसकी स्कैन कॉपी लगा दें, राइट
Yes,
डॉक्टर
yes.
शायान? दैट्स
Put
व्हाट वी
out the
आर।
entire report in the slide so
राइट,
that
ठीक है,
the
आई थिंक
histopathologist can read, go through it. What
राइट
are the
राइट, हाँ, सो
findings at least until we
राइट
get the slides.
राइट, बिकॉज जैसे डॉक्टर जैनब ने बताया उसके बाद डॉक्टर आयशा ने, so we could
See,
only
Dr.
imagine.
Hasan, if the cases are from AQ, you can always share the pictures in advance. If you just give me like 1 or 2 days, so I will share the pictures.
That's
Images मैं
perfect.
आपको पहले से भेज दूंगी.
Thank you so much. Thank you. Thank you.
So one of the important thing, Dr. Hassan, considering the differential of neurofibroma versus schwannoma, the management is somewhat different if we are from seeing that from the respiration perspective. So that's why
Right.
it is very important to actually establish whether we thought this as a neurofibroma or there is a possibility of schwannoma associated with it. So it is better to have a discussion with regarding the histopathological findings with your primary histopathologist, so that we have, because the follow-up the the follow-up guidelines need to be a little bit modified if we think it is a schwannoma. So that's why it got the particular importance to differentiate between the two.
बिल्कुल ठीक है। So इस केस में मैं ये भी कर दूंगा, डॉक्टर आयशा को भी भेज दूंगा और डॉक्टर जैनब को भी, जो हमारे पास बायोप्सी की रिपोर्ट है, एंड आई थिंक दे कैन आल्सो टेल अस वेदर इज देयर एनी डाउट। जैसे उन्होंने बताया कि मोस्ट ऑफ द टाइम इट्स अन लाइक देयर इज नो डाउट, लाइक इट्स वेरी क्लियर, बट स्टिल आई वुड शेयर द रिपोर्ट विद देम। अच्छा डॉक्टर यमुना, वी कैन प्रोसीड टू द नेक्स्ट केस।
Yeah.
Okay, please.
And this is a case of a 35-year-old male. He presented, he had a history of neck pain, weakness of hands, difficulty ambulating, and dysphagia for the last 5 years. His initial exam didn't show that he has a gross weakness of small muscles of hand and forearm. The upper arm bulk was normal. His deep tendon reflexes were reduced, and he had glove and stocking hypoesthesias along with the fasciculations in the upper lower limbs and tongues, and he had a pigeon-shaped chest and scoliosis. He was a kind of a proven case of chronic inflammatory demyelinating polyneuropathy since 2021. His initial MRI in 2023 showed an increased lordotic curve and moderate central to paracentral disco-osseous complex at C56 that was causing thecal sac indentation with canal narrowing and compression of the cervical spinal cord. Initially, he was managed on the lines of motor neuron disease. A repeat EMG NCS in 2024 confirmed that he had a mixed variety polyradiculopathy that was affecting his all four limbs. He presented to us in 2026 with the complaint that his symptoms were progressing and they were totally unresponsive to steroids. We got another EMG NCS done by the neurology, and it showed severe chronic sensory motor axonal polyneuropathy. We were actually doubtful that the guy had motor neuron disease, so we sought for a neurophysician opinion. He got an MRI, which showed that there was a kind of a fusiform soft tissue lesion. Um, we have
हम
MRI.
यमुना इसमें डॉक्टर उनसे शायान से पूछ लेते हैं बट आई वांट टू गिव लिटिल बिट ऑफ यहाँ पे भी एक वो कि इट्स अ वेरी इंटरेस्टिंग केस फॉर द बोर्ड टू अंडरस्टैंड सो दिस young guy got diagnosis of MND motor neuron disease or ALS so and for 6 years he lived with that diagnosis and then wherever he went and he was told, look, just looking at the EMG report, कि जी ये MND है, ALS है, so there is no treatment, you can just go home. So when he came to us, so I told him, like, I'm not a neurologist, but your symptoms just do not match with MND or ALS. Let's get an MRI with contrast. उसका पहले MRI हुआ था, कभी contrast के साथ नहीं हुआ था. MRI करवा लेते हैं, but go see a neurologist and repeat EMGs and at my center so that I can have discussion with the neurologist कि है क्या issue. I have not seen usually MND ALS patient with these symptoms. Then we had this discussion and then we got this MRI done that showed very different picture and then we have the biopsy. So this poor guy lived 6 years with the diagnosis of almost 6 years of MND and ALS with no hope कि भाई that's it. So I have to just live this way or maybe just die because there is no treatment. So Dr. Shayan हम अब उस पे चले radiology.
All right, so this is imaging done in March 2026, and these are limited sagittal T2 weighted images in which you can see that there is exaggerated cervical lordosis, and of course there must be some element of scoliosis as well. That's why we are not getting that midline image. In the second image, we can see that. There is the quad is separately visualized, and we see a discostified complex at 5-6 level, which is the kind of moderately indenting the thecal sag, but not any compression over the cord and no signal abnormality at this level. But in the lower row, if you look at the neural phenomena, we see multiple lesions which are kind of rounded and thickened following the nerve roots. Ehsan, can you point it out or can I have the pointer?
No,
Yes.
yeah. मैं आपको भी वैसे I can get this.
Yeah, exactly. So these are the thickened nerve roots, which we can see at the level of neural phenomena. This is, of course, off center. This is off midline, and we can appreciate all these nerve roots are thickened, and this is best visualized on T2 fat sat image, as you can see here. So this again is a T1 plane image. Of course, not much information is over here. Next. This is a midline image, and again, we see no significant. Again, we can see these thickened nerve roots, but of course, since it is not enhanced, we cannot really appreciate them very well, as in the prior image. So these are the axial images, and you can see the localizer on the top left, and we have covered all these levels. And over here, if you look at the each neural phenomena level, you can see some lobulated soft tissue, which is occupying the dorsal nerve root and the nerve proper. And if you look at the thecal sac at these levels, these are very well visualized. But in the lower, right corner, you can see that there is some extension of soft tissue within the thecal sac involving the ventral as well as the dorsal nerve root. So these are multiple nerve involvement, and I think, all right. So this is again a second scan done with post contrast.
Yes.
I suppose. Okay.
Yes.
So at this level, you can see at the level of thyroid cartilage, which must be around C4, C5. We can see that this is. These are lobulated soft tissue, which is extending intradurally and causing contour deformity of the cord. As you can see that it is appearing slightly triangular rather than oval shaped. And These are also showing extraforaminal extension into the paravertebral soft tissues. You can see some lobulated soft tissue adjacent to it as well. Yes, here and on the left side as well. So again, fat suppressed images, better visualization of the nerve roots, and you can see they are extending all the way in the dura and causing contour deformity of the cord, and also showing extraforaminal extension. I think these are videos. The
Yeah.
first video is we can exclude the okay. So the middle video is
Should I go to the next one?
yeah.
Okay.
Basically, these videos are not covering the lesion fully because they have
Right.
limited field of view. But if you scroll the first one, the axial one,
Okay.
so in this we can see that the brain parenchyma visualizes appears normal, and the both vestibulocochlear nerve complexes are also clear. Like we do not have any schwannoma over there. And as we go down, we start seeing these levels, because of course this is a very small field of view, that's why it's not very much appreciable, but you can still see that these lesions are still there, and on post contrast they are not showing very significant enhancement. Very mild enhancement is over there. They are very poorly visualized if you compare with the thyroid enhancement, but they are definitely there.
ये वाली भी प्ले करूं या
ये भी
just
कर लें प्ले, लेकिन इसमें ना वो कवर नहीं हुआ हुआ, वो
right?
थोड़ा सा फील्ड ऑफ व्यू उन्होंने बहुत लिमिटेड रखा है ना, द सेंटर ऑफ, तो उसमें वो लीजन्स जो है वो प्रॉपर्ली
Covered
कवर
नहीं.
नहीं है. बट हियर यू कैन सी दैट दीज nerve roots are thickened, and I'm surprised. I don't know why these lesions are not showing enhancement. Probably there can be some schwannomas which do not show enhancement, and they are melanotic in nature, but of course on T2 we do not see them behave like that.
So, Dr. Shan, based on the radiological finding, what would be your differential in this particular patient?
Okay, apart from the lesion which we saw at C4, C5 level, they are bilateral dumbbell shaped. They are behaving like schwannomas. But since my initial impression was that since there was multi-level involvement of the ventral and dorsal nerve roots and the nerve proper, based on the clinical history which was shared with me, my first differential was CIDP, that is chronic inflammatory demyelinating polyneuropathy. But then I saw this lesion at this level, but these lesions are possibly present only at this level. So there may be a diagnosis of CIPD with concurrent lesions as well. CIDP with concurrent lesions as well.
Okay.
Other differential will be that of schwannomatosis, which occurs in isolation, and it is different from NF2 type schwannomatosis. So here we already excluded NF2 because there are no schwannomas in that vestibulocochlear nerve complex level. So if there are multiple schwannomas, then we can consider schwannomatosis. Other than that, what was coming to my mind was I just read on it. It can be Charcot-Marie-Tooth syndrome disease. If anybody, any medical physician can, elaborate on it. Charcot-Marie-Tooth syndrome, because they have pigeon-shaped chest and they also have this CIDP thing, hypertrophic neuropathy. Not CIDP, hypertrophic neuropathy.
एंड डॉक्टर शायन अगर ये हमारे पास यहाँ AQ में होगा ये तो वी विल रिपोर्ट ये पॉसिबिलिटी हम इसमें यही 2-3 चीजें मेंशन करेंगे राइट
जी बिल्कुल, because this is basically hypertrophic neuropathy. Most of them are not showing enhancement. If there had been some active disease, there must be some enhancement. But since there is a definite tumor-like extensions and lobulations, so at least 2 lesions are definitely behaving like a neoplastic lesion rather than infective inflammatory. So, but the rest of the levels, I believe they are only hypertrophic neuropathy.
Okay. Yeah. Okay. And the histopath came as the nerve sheath tumor schwannoma. ये भी डॉक्टर आसिम वहाँ एसकेएम गई थी हमारी सो वी सो डिड विद इंटरनेशनल रेडियोलॉजिस्ट परफॉर्म अल्ट्रासाउंड गाइडेड बायोप्सी सो उसको ये आई है हमारे पास डायग्नोसिस सो सर व्हाट डू यू थिंक नाउ विद दिस काइंड ऑफ disease or surgery तो I mean like in my humble opinion will be very challenging एक तो मल्टीपल लेवल्स हैं फिर आप अगर देखें ना वो डिफ्यूज डिजीज है कोई अलग से वो चीज अलग से कोई ट्यूमर नजर नहीं आ रहा दैट वी कैन जस्ट स्कूप आउट so is there any role of radiation or what we should do?
So as far as radiation is concerned, Dr. Atam, we have also have the same challenges that we have mentioned. Because it is a diffuse disease, so it is difficult to say what to target, what not to target. Okay.
Right.
So looking at the scans and the finding described by Dr. Shayan, I don't think so. Okay, radiation would give a because patient symptom also is not very specific to a particular level. So if it is a specific to a particular level and surgery is not possible, then one can think of any possibility other than surgery. But because of the symptoms and the radiological finding, we combine both together, then radiation considering radiation therapy, I don't think so is a will give some benefit to the patient.
और अगर फ्यूचर में उसकी ऐसी कोई पिक्चर बनती है जिसमें वी हैव दैट पर्टिकुलर लेवल उस वक्त हम सोच सकते हैं रेडिएशन का या उस वक्त भी हम पहले सर्जरी ट्राई करें सी व्हाट वी कैन डू डिकम्प्रेशन वगैरह एंड देन वी प्रोसीड टू द रेडिएशन.
So the important thing is that because these are benign lesions, so the impact of radiation therapy in removing or in improving the symptoms of the patient immediately is very less. The purpose of giving radiation therapy to is provide a local control in the long-term period. And that is the main
जी
goal.
जी
So if a patient is already symptomatic and so we usually require the neurosurgical help actually to decompress it so that the patient get relief from the symptoms. And then one can think of giving radiation therapy for local control, but it may takes a very long time to actually show its effects. That's why usually for symptomatic patient, the surgery would be the first choice to begin with.
डॉक्टर आयशा सो इसमें हमें कोई वैसे मैं आपसे शेयर कर दूंगा अगेन द एसकेएम के हिस्टोपैथ है व्हाट डू यू थिंक इसमें कोई डाउट वगैरह हम अगर रखते हैं या कुछ और वो रिपोर्ट से वाजे हो जाएगा या इफ यू वांट टू ऐड एनीथिंग फ्रॉम हिस्टोपैथोलॉजी पॉइंट ऑफ व्यू रिगार्डिंग schwannomas?
I'm not really sure कि specimen size क्या है और वैसे तो they are very classic and distinctive lesions and I don't think there should be any difference in the diagnosis. But ये अल्ट्रासाउंड गाइडेड बायोप्सी मैं वही सोच रही थी कि कितनी बड़ी ये बायोप्सी थी और उसमें कभी कभी हाइपरट्रोफिक जैसे नर्व ट्रंक्स होते हैं सो उसमें आप कभी कभी यू कैन कंफ्यूज देम विद जैसे schwannomatosis और से सो बट वी कैन लुक इनटू दैट मेरे अगर कंप्लीट की रिपोर्ट आती है तो आई कैन देन कमेंट बेटर ऑन दैट.
ओके ठीक है. एंड डॉक्टर जैनब एनीथिंग एल्स दैट यू वुड थिंक? मैं आपसे शेयर कर दूंगा इनका एमआर नंबर, आप अपने एंड के ऊपर भी देख लीजिएगा इफ यू गेट दैट. वो इमेजेस भी अगर आपको मिल जाएं. If there is any doubt, then maybe we can think of repeating biopsy. Otherwise, I think जो भी डॉक्टर आसिम ने suggest किया है, we can continue to follow the patient and then.
जी ठीक है डॉक्टर हसन आई डोंट हैव एनीथिंग एल्स टू कमेंट इफ आई कैन गेट द एमआर नंबर जो आप कंप्लीट रिपोर्ट शेयर करेंगे उसमें अंदर पेशेंट आइडेंटिफायर्स तो होंगे ऊपर ना एमआर नंबर और वो तो उससे ट्रेस करा के आई ट्राई माय बेस्ट.
Okay, perfect. ठीक. So, but this was very interesting case and poor guy, young guy, बेचारा इसमें वो है. Let's see. Anything else from our participants? Quick question, please. You're free to ask.
So one of the thing, as mentioned by Dr. Shayan about the hypertrophy and all this kind of or the inflammatory process, I would also like to have a discussion with the neurologist in the
जी
context of all this discussion. So what is there, because there's a lot of term that has been described by Dr. Shayan that is beyond our,
right
particularly myself, beyond my expertise. So it is very difficult to actually comment on that particular aspect. So neurologist would be the right person to have identify the syndromes and then move along that side. Yes, there is a we have a diagnosis of this thing, but there are a lot of changes associated or visible on the MRI that is not explained by this simply this schwannoma. So that also need to be looked after so that the patient get benefit from this discussion. Thank you.
Yes,
बिल्कुल
I
सर
agree with Dr. Hassan. Yeah.
बिल्कुल ठीक अच्छा डॉक्टर आसिम इसमें न्यूरोलॉजिस्ट के साथ हम बहुत वो रहे हैं काइंड ऑफ क्लोजली लिंक्ड रहे हैं ही आल्सो गिव him the trial of steroids thinking about kind of any inflammatory और वो उसमें अगर तो उसमें भी कोई उसको improvement नहीं आई but we can have another discussion we can tell all these differentials that we discussed today and then we can have another session and then inshallah we'll proceed.
Yeah, totally agree, Dr. Hassan, but the finding that described by Dr. Shah is
जी जी
somewhat
बिल्कुल
because this is not my expertise now, so that is why you are the expert or the neurologist will actually guide us more or give us more insight about the disease process itself. But from particularly from this lesion that had biopsy, explain all the symptom is difficult to
बिल्कुल
to align the diagnosis and the symptoms.
बिल्कुल सही आई थिंक यमुना ने शेयर किया है टेक्स्ट फ्रॉम द बायोप्सी के it was an encapsulated lesion composed of blank looking spindle cells with hypo and hypercellular areas with verrucate body formation ठीक no atypical cells
So
okay
if you're talking about the ultrasound guided biopsy, would it be possible to have a intact capsule reported on that particular specimen? Because usually you have a small
Exactly.
yeah
uh,
I was also
yeah
thinking the
yeah
same कि
because
ये
that through cut
कितनी बड़ी
biopsy
biopsy
ये
है.
बात आपकी सही है बिल्कुल कि हाँ ठीक है आई थिंक वी कैन डिस्कस दिस आई डिस्कस दिस विद डॉक्टर जैनब शी इज एट आवर हॉस्पिटल and she was in SKM. We can have this discussion. I'll share the report with Dr. Aisha also. और अगर मुझे वो images मिल जाते हैं तो हम वो भी discuss कर लेते हैं so that we would not have inshallah any doubt on this. And अगर होगा तो then we can have another discussion. Maybe we can discuss this case again. So I think
So,
that would.
Dr. Essence, it is not surgically amenable to surgery.
सो डॉक्टर शायान हम सर्जरी कर सकते हैं जैसे डॉक्टर आसिम ने बात किया इससे पहले भी जो मेरा कमेंट था वो ये कि बिकॉज वो डिफ्यूज डिजीज है और आप अगर देखें ना तो वो नर्व और उसको वो अलग से नजर नहीं आ रही अच्छा अब जो ही इज एबल टू वॉक एंड द मेन इशू इसका हाथों की ग्रिप और मसल वीकनेस एंड पोस्चरल चेंजेस दीज थिंग्स he has. So, I mean, we can do surgery, we can do decompression, and then planning of if we are able to remove some part of the tumor or the disease, we can do that. लेकिन अगर मैं सारे उनके ऊपर जाता हूँ बायलैटरल न्यूरल फोरामेन सबको खोलना एक एक सबको वो निकालना दैट विल बी वेरी वेरी एक्सटेंसिव सर्जरी और मुझे ऐसे लगता है कि perhaps it would have more morbidity, more complications rather than जो पेशेंट को फायदा ज्यादा हो उससे but if it would be on one or two levels, then of course, it would, we would have, I tried and we can still try. लेकिन ये है कि in my opinion उसमें morbidity ज़्यादा है extensive disease होने की वजह से
Right,
so
I agree.
how is the patient's progression of symptom over this all this time?
ग्रेजुअल है सर उनकी जो डिटीरियोरेशन कह लें वो सो अभी वेट लॉस भी है बिकॉज ऑफ ओवरऑल एक तो उसमें थोड़ा साइकोलॉजी वो भी था बिकॉज वेर एवर एंड दे वेंट दे सेड कि कोई इलाज नहीं है करके बट सो उसमें दोनों तीनों चीजें थी ओवरऑल ड्रामेटिक उसकी डिटीरियोरेशन नहीं हुई 5-6 सालों में so he is still able to. He has a family. He has children. So all these things. Lekin he looks like kind of getting weaker. एंड द मेन थिंग जो मसल लॉस है उसका अपर बॉडी में और खास तौर पे शोल्डर्स एंड फोर आर्म्स एंड हैंड ग्रिप रिड्यूस्ड एंड ऑल दीज थिंग्स.